So this is going to be a NeuroPace RNS implant for epilepsy, and with the RNS, we're accessing basically anywhere in the brain that we find the seizures to be coming from. So we might be putting in depth electrodes, we might be putting in strips. I have an example of each of those here. I'm not really going to demonstrate a strip implant today because it could be, again, anywhere, and really most of the time we just make a burr hole, slide it into the subdural space, and then tunnel it. Complicating things would be any previous surgery that they've had for epilepsy. So oftentimes they might have already had a craniotomy done, and you might want to, use the previous craniotomy as an access to get it there. That can make it a little more difficult if there's scarring or anything. But ideally, you're making a fresh burr hole and sliding it subdurally, and then typically just tying it and tunneling it from there. So that's the strip. There are only 2 electrodes that can be implanted with the RNS or hooked up to the RNS, but oftentimes people will put in even 4 electrodes and then only hook up 2, and that way if one of them isn't working, isn't on the onset area, and you want to plug in a different one that you've already placed, then it's just a subcutaneous surgery as opposed to going intracranially again. So oftentimes, particularly if you're placing strips over like a motor cortex onset, we might put in 4 strips right next to each other, only hook 2 of them up, and then if we don't get good onsets or we're not getting a good response, then come back later and switch out one or both of them to get better onsets. So, but for right now, the most common one is going to be your temporal lobe epilepsy. Most common of that is the bilateral temporal lobe epilepsy. So we're implanting bilateral depth electrodes, and the trajectory that we use is going to be very similar to what Dr. Koh is going to show with the visual aids. Generally, we start by getting a CT scan and an MRI scan, and then co-registering the 2. And you can see here that we've already got the CT and the MR, and I've already basically created a trajectory for a left hippocampal depth electrode. I'm only going to show the left here, and you can see that there are 4 contacts of the depth electrode, and there's either a 10 millimeter spacing or a 3.5 millimeter spacing between the electrodes, and we pretty much always use the 10 millimeter spacing with hippocampal depth electrodes, and that allows us to get essentially 1 contact in the amygdala typically, another contact in the hippocampal head, and then hopefully 2 contacts in the hippocampal body. And that's kind of what we're going for. Generally, if we can avoid the ventricle again, it's probably better, because it is possible that when you place a depth electrode, it can go, if it's going through the ventricle, it could deflect off the ependymal wall of the hippocampus, and it is a little bit high angle when you're approaching it from the back. So it's probably better to go underneath the ventricle if you can, although I've had many patients where we've gone right through and it's ended up fine. The caveat is oftentimes, if you're going to be placing an electrode with the Lexel frame or any frame, CRW included, you generally need to get these screws in as low as you possibly can, because otherwise the arm's going to be in the way of the burr hole. And you can see here, we probably could have put these screws in a little bit lower and made it a little bit easier on ourselves. I've already kind of planned the entry here based on this trajectory. So thinking about putting on the frame as low as possible is a good idea if you're doing hippocampal depth electrode placements. It doesn't have to be done with the frame. You probably could use the next frame or ClearPoint or even a Vertec arm or Vario guide. I probably would not recommend using the Vario guide at this point, or the Vertec arm with the Medtronic frameless, because I'm not sure that the accuracy is as good. Basically, you want to get a 2 millimeter or less accuracy with whatever method you're going to use. And the frames are very tried and true, and I feel like they're the most reproducible for placing these depth electrodes. So here we plan the trajectory, and we've used the Lexel frame. You have to be careful that when you're defining in your software, whether it's the FrameLink software with Medtronic or this software software with the Brain Lab that you have the correct frame selected and the correct orientation, because you can put this on either X is left or X is right, and that will end up giving you opposite coordinates if you don't select the right thing. So here we have our target right here in the amygdala. We're heading through the hippocampus. It looks like we're heading fairly just below the ventricle, and we can just check that going through here. We're kind of barely squeaking below the ventricle here and trying to avoid any deep sulci that have an artery in it. And so this looks pretty good as a trajectory. Okay, so we find our arc settings then, and you can see here we have lateral is right for our Lexel arc. And you can see we have X 121, Y of 101.3, and Z of 117, ring of 166.7, and arc of 100.6. And I've already set those here, so I'm just going to swing this out of the way now. And actually, I'm going to demonstrate. There's two different depth electrode lengths for NeuroPace. There's a 44 centimeter depth electrode, and there's a 35, is it? Where's Chad? 30 centimeter depth electrode as well. The 30 centimeter depth electrode is not long enough to be held by the microdrive, which is typically used by people who also do DBS. So if you're going to use your FHC microdrive, then you have to use the 44 centimeter depth electrode. Otherwise, it will not be long enough to be held in your construct here. So we'll use since we're going to use the Fred Hare drive here, we're going to use the 44 centimeter depth. So we'll start by making our incision. And just a little bit here. And oftentimes I'll tunnel a area underneath the skin afterwards. We've already opened up the cranie here, but we typically do the depth electrode placement first, just to make sure there's no air that gets intracranially and allow us to have a more accurate placement. So X. Most live patients, it's not so hard to tunnel. And NeuroPace has their own Burr hole cover to lock it down, but it also uses a 14 millimeter round bit that you typically would use for DBS. So pull straight out. Pull straight out. Here, I'll let you do it. Nice. All right. Well. So again, usually I will, after I open up the skin, I'll come back and make sure that my trajectory lines up so that my burr hole is going to be in the right spot. Well, looks like we didn't get all the way through. So, all right, we'll open up the dura and we'll put on the Burr hole cover. So the NeuroPace Burr hole cover is designed a little bit differently than the Medtronic. There's only one locking mechanism, which is this membrane, the clear membrane that's put in at the end. So there's no temporary locker, so you have to be a little bit more careful while you're taking everything apart that there's no movement. And so there's also, generally you have to use a plating kit because the screws, there are no screws included with the Burr hole cover, so you have to kind of use whatever system you have for cranial plating. And there's a pre-curvature built into the Burr hole cover that sits relatively flat on most skulls, but not always. And so it's better when you're putting in the screws for this. If you tighten one down all the way right away, you'll oftentimes have the other side riding up a lot more. So it's better to put them all in kind of halfway at first, and then go around like a tire and put them in, tighten them up the rest of the way. And I typically use about a 4mm tie mesh screw for these Burr hole covers. So we don't have quite enough screws here, so we'll stop at 2 here. And so if you're going to be using the 44-centimeter electrode, where's the, do we have the measuring device? Yeah. So I'll just use the same measuring device as we use for DBS. And, oh, God, this makes it easier to get the length of your electrode. And I typically will measure so that the bottom of the zero contact is at target here, and that's 375 millimeters. And you can see that if we use the other electrode, it's simply not going to be long enough to get all the way there. And then, as usual, you want to not forget to take this off and put it on your micro drive. So we'll swing this down. And this is a little bit different than most DBSs because you're coming from such a posterior perspective, and there's no reason, you don't have to pick ACPC at all. We're not using ACPC coordinates, so there's no reason to do that ACPC on your targeting. And let's see, we're doing 100.6 and 166. So I'm just going to put that on. And we won't demonstrate, we're not going to be able to get a post-op CT for this. And normally I would, oops, hold on, I need my cannula. Do you have the cannula over there as well? That's the operator.
Oh, here it is.
Oh, great.
Grab that one too. That might be. One of those might be the two. One of those might be the sharp one.
Oh, yeah. Does this have a top to it? Oh, yeah, it does. Great. All right, sorry. So we'll put our cannula in first. What's that? Oh, that's the slotted cannula. I'm using that would be for the shorter electrode. So again, this is the method for the longer electrode. There is a method where you can use a shorter electrode, the 30 centimeter, but we have to then use a slotted cannula for that. So we're going to place that. So, and then when you're using the Lexel frame, it's always important that your zero is zeroed out here at the Lexel frame, as well as that your depth is at 30, because otherwise you will not be at target. So we'll drive this down to 30. Okay. And then basically, you can deploy the electrode. You generally have to have, it's better to have two people and have one person kind of slide up the cannula. And then I typically will mark the electrode at the level where it leaves the burr hole cover to make sure that if it moves at all, I'll recognize that. So just kind of mark it right here. And then typically have somebody hold this while we deconstruct. So we'll take out the stylet, and we'll take out the stop. And take out the cannula. And then you can slide this up to get a little more working room if you need to. And then typically I get like a Penfield 4 and hold it over on the side while somebody else puts in the stop. So, and that's it. Generally you want to undermine around it as well, because just like a DBS electrode, there's usually some extra electrode, and you're either going to have to put it back here, or you're going to have to put it by the IPG if you have any extra electrode. But you're going to be coming back to replace IPGs in the future, and so you want to have this as clean as possible. When you're picking the site for this, you want to have the leads go off of the device in a way that you're not going to be cutting over any electrodes in the future, okay? So we've kind of already picked a more or less ideal spot. This device has a curvature built into it that was really designed for the parietal curvature of the skull. We're a little bit anterior here, but typically about right here is where we'll end up placing it. You can put it on either side. I usually try to go to the non-dominant hemisphere just in case there's any dural renting. And there's do we have the template here? Here it is. So when you're actually designing even where to make the incision, I'll typically take this template, kind of put it on the scalp and see where it fits the best. And then you have to be careful because the electrodes will always come off of this side of the template. And so I try to design my skin incision so that it will be coming off into the flap, underneath the flap. And that way, if I put it this way, then the electrodes would be coming off here and going underneath one of my incisions. So if I wanted to come back later, I'd be putting those electrodes more at risk. These are not well protected electrodes. So again, I'll put that on the skin, then I'll mark a U incision right around that, which we've already done here, open it up, and then you can place this right in the bone. And the hardest part of the case is actually trying to draw around the template with a pen without moving it the entire way around. And Daniel, our fellow here, has already done that beautifully. So then basically I make a burr hole and then a side cutter to cut out the craniectomy. And then you're making the craniectomy for this. This is called the ferule. And you can see the ferule has 4 pieces that will attach to the skull. There's also a little hook here that holds the battery in on this end. And then there's a locking screw right here, which will go over the battery when you lock it down, and that's what holds in the IPG. So you have to make sure that they're all available and not blocking, not being blocked by bone. So let's see, you can also see that with 4 tabs, unless you have a perfect sphere that you're putting it into, there's a good chance that one tab or the other will be elevated over the skull. And so you may have to overbend one tab or the other to get it flush onto the skull. And so the goal in the end is to get it deep enough such that once the battery is in, it's flush with the skull. So I would probably bend these down a little bit more to get it a little bit deeper. And when this comes, there's actually all of the tabs are up except for one. There's one that's pre-bent, and the rest you have to bend yourself. So typically, I will bend a little bit less so it sits a little bit deeper, and then it's not as palpable later. So then we want to put it in. Not exactly perfect, but. And then we'll screw these down. I'll just do one. And I guess so again, having all 4 tabs sit flat can be a challenge, and oftentimes you're using like a 4mm ball to go around the edges of the craniectomy so that it will sit fully flat against the dura. If there's anything off, then this ferule won't sit flat. And Chad, do you have a tunneling tool here or not? No? Okay.
Just the straw.
Just the straw. Okay. So put in 4 just like that, and then we'll put in the device, and we'll. Do you have the torque wrench?
Sorry.
So key also is to make sure after you've put it in, you have to tighten down the torque wrench. Otherwise, this thing is not locked into place. And then you can see here that this is where the electrodes are going to come off. And so typically, I will try to undermine the skin, the galea here, so, and like a nice pocket down here so we can fit any extra electrode underneath this flap. And so, let's see, do we have a, I'm going to tunnel with a pituitary. Typically we will have a tunneler. You can use a shunt tunneler, or you can use, they have their own tunneler as well. But basically, you just want to get it from one end to the other. Do we have a tonsil or anything, do you know? We're a little bit far. Well, that's not quite right. So I'll just open this up more. You got one? Thank you. So often a tonsil will do it. We're a little bit more anterior on the frontal bone than we typically are for an RNS. So they're not usually such a long distance to travel. And typically, maybe I should just show the safer way of doing it. And you can put the straw in there and bring it through. And then pass the electrode through the straw. And so again, generally we want to keep that electrode away. So I'll tuck it underneath the galea and bring it down. And now we have the electrode coming up to the IPG. And there's one more piece. This is the cap. And typically we'll have two electrodes, so there's one on each side. We'll have two coming up into here. You can see they're numbered right here, 1 and 2. And typically for a left, we put into 1, is that right? We put a left side into the first port and a right side into the second, just for consistency's sake. Then you can see, I don't know, yeah, if you can zoom up, but each of those little metal tines is a contact right here, and so you want to be careful not to let any moisture into this area. There's actually a seal that will go around all of the contacts once it's closed, but you want to make sure to suction all this off and make it as clean as possible before you lock this down. And also, what you probably can't see here is that on each electrode is a little amber line, and when you come back up here later afterwards, I don't know if you can see it. Oh, nice. Almost. Anyway, when the amber line, when it's fully engaged, the amber line is right up flush with this cap, and that's how you know that it's all the way in. And then you lock that down completely. And then there is a strain relief cap as well. Do we have that here? Oh yeah, here it is. So this little strain relief cap, if you do happen to put it in an orientation where it's crossing the incision, and sometimes, you know, just that's what works out to be the best, then that strain relief cap will really protect you if you're coming back later and have to cut over it. So, and then typically also, I didn't show it, but we often will take a little bit of bone out right here, because this strain relief, if you don't feather the bone on this edge, the strain relief will stick up more and try to poke out through the skin. So I'll typically take a 4mm round and just kind of feather the edge of the bone right here, so there's a little bit more gentle of a transition to the over the skull space. And so once that's on, then we basically close up. And I do now all of these cases in with the arrow, and so we're actually doing it right through the bore of the arrow, and then as soon as we're finished placing the electrodes, we will get an arrow scan and verify that it's in the right place, and then go ahead with the RNS implant afterwards. So generally there's, 3 incisions, 1 for each of the 2 depths, and our parietal incision here. So that's it. Any questions on the RNS?
How do you close the skin, and what do you tell them for wound care?
Oh yeah, great. So everybody's different on how they like to close. I personally think that, infections are a big risk for these patients, and you are coming back oftentimes. I think I have one patient that I've had to go back in 6 times. And so having a really good closure that's not going to, end up with a really thin skin is very important. And I believe that making sure that it stays a 2-layer closure is the best thing. And so making sure that the Galea is available on both sides to bring together is very important. Tons of irrigation with antibiotic solution, at least 3, big bulbs. And then I try to undermine actually as much as possible, particularly for redos when you're changing the battery. Oftentimes it's cemented right onto the skull, and if you don't undermine it, then you can't bring that galeal edge back together again and get a good deep closure. So I'll use 2 Ovikes for the galeal layer, and then I use a 4O monocryl, which is an absorbable suture, pretty thin, and I do tiny little stitches all the way through the dermis, and then I put glue on top. And so there's nothing to take out afterwards. You get a very good watertight 2-layer closure that way, and it's pretty darn cosmetic as well. So the only thing they complain about is that glue is like coming out of their hair for like 3 months afterwards. So, but most people don't mind that as long as there's no infection. So, any other question?
How often have you changed the battery?
Yeah, the battery has lasted anywhere between like 1.5 years and maybe 4 years for the RNS. Probably about 3 years is what we're getting out of them now. They keep saying that one is going to be coming out very soon, correct? Any date?
No.
No, okay. Sometime in the next year, I've been saying that there will be one that has a projected battery life of 5 to 8? 5. I'll believe it when I see it. So maybe 8. I don't know. It'll be a lot better than the one that we have now, and hopefully that will diminish the number of redos that we have to do. But if you think from the study, it's been about, I think, a 2.5% risk of infection per operation for that patient. So obviously the more you have to do, the more you're exposing them to over time. And likely, I think they've looked, and the risk of like the 5th change is not worse than the risk of the 2nd change, but any change that you have to do is not ideal. So, any other questions?
Why can't you have a battery on the chest with an ABS?
Yeah, well, it wasn't designed that way in the beginning, and the reason that I've been told and that makes sense to me is that this is an unamplified signal that's going from the cortex to the amplifiers in the device, and so while it's traveling through the wire, it's very subject to noise. So any movement of the wire can introduce a lot of noise into the system. So the idea was to keep everything as short as possible and as fixed as possible. And I mean, the recordings that we get are beautiful. I mean, they're gorgeous recordings. Whether or not in the end we could have gotten away with one that was further away, I don't know. But it's actually a very cosmetic result after the hair grows in again. But it's a little more difficult because you're stretching the skin over this fixed object. So I think as long as you are really, really careful about how you close it, it actually is a very good cosmetic result, and there's no battery below. So.